My talk is on where's the current need for research trials. It's everywhere. You've already heard. We need everything. These are my conflicts, relationships. I start with a manuscript that was written some 40 years ago by one of my mentors, Jim Dallin, who defined what the natural history of pulmonary embolism was in man if you didn't do anything. And I would say that we haven't really made a lot of really hard evidence-based progress since 1969 when he wrote that article, and we have a long way to go. So this is a crisis. A PE kills almost as many patients as stroke, and yet the data evidence in this area is much less than it is in stroke. Most patients don't receive advanced therapies, and in spite of the incredible morbidity and mortality associated with this disease. And the CDC calls it really a public health crisis or concern, and you've heard about this already, so I won't go into it in too much detail. Yet the global awareness of PE and DVT is much less than that of diseases that kill many fewer patients and really affect many fewer patients, including AIDS, for example, and which has huge public awareness, breast cancer, but yet PE is much more devastating, and I don't want to take anything away from those other illnesses, but it's much more prevalent. So this is really a call to arms. And 2 nights ago, we had a 52-year-old woman who was status post gastric bypass or sleeve gastrectomy, who was admitted to MGH. And she came to the ED. I was called urgently down there with my fellow, and she was literally dying. I will tell you that she had her O2 sats dropped to the 60s, her blood pressure dropped to the 50s while we were down there. She was pale, underperfused, and had terrible chest pressure. Her tachycardia went up to 150, 160 while we were there, and we couldn't get blood pressure in the cuff. Now, the worst thing to do with that patient would be to intubate her, because her whatever pressure she had would have bottomed out. This is her EKG. You can see RV strain. And we couldn't get her to the CT scan, but the echo showed that she had really global RV dysfunction. So the ED, while she was crashing and we were on our way down, they decided to give her IV thrombolytics. Now, there's not a lot of evidence base for all this. I mean, that's probably more in IV thrombolytics than anything else. They gave her a 50 milligram bolus, and I came down, I said, we need the ECMO team. She's still hypotensive, tachycardic, and she's crashing. So, she's on 3 pressors, epi up to 15 and levo up to 100 and so on. So we, while we were getting access, and I got access for ECMO to crash her onto ECMO, she actually started getting a little bit better and started actually being able to converse with me a little bit. And over the next 30 minutes, we sort of got access, waited at the bedside, and she improved and decided to defer ECMO. And she got completed her infusion, was weaned off pressors, and was admitted to the MICU and actually did incredibly well. And this is what her CT showed the next later on that evening. So, but all of this was done in sort of this is the art of medicine. It was standing by the bedside, trying to figure out what to do with this patient who's crashing. And, so I would ask, the first question is, research question number 1, what's the role of systemic lysis in today's management of PE, given the PYTHO trial that you've heard some about, and the availability of the therapies that Jay described and our surgical colleague described? What is the role of all these things, and how do we figure this out? I'm not going to do this case, except to say that Jay brought this up. What's the optimal therapy for clot in transit? Many people would say it's directly to the operating room, no? And we still do that a lot. But then there's this other device that actually extracts clot. And then there are some in Europe, if you talk to some of the Europeans, they'll say systemic thrombolysis is the way to go for clot in transit. You don't have to remove it. So there's a lot of controversial opinions out there, and none of them is proven, none of them is evidence-based. That's a research question that needs to be answered. It's hard to accumulate enough patients to do that, but it's upon us to do that in the future. So one of the biggest challenges in PE therapy in the standard one without clot in transit is figuring out who's most in jeopardy, because if you identify those in jeopardy, the worst in jeopardy, they have a 30% mortality. But then this high-risk intermediate group that has been described by Jay and others is really still not so low. I mean, and Jay, I just will challenge. I mean, you showed your slide of the different the mortality and the way that the low mortality in this intermediate risk group, but it's all about who is in that intermediate risk group. Who are we defining as in that category? And I would say a lot of them are probably the lower intermediate risk. Some of them are the high intermediate risk, and we just don't have a good sense of how to define these in a continuum and how to really assess their risk. So, and in fact, so much so that this European study showed that the Gestalt factor is better than all those scoring systems we have, the PESI, SPESI, PERC, and all the PEPSI, all the different scoring systems. They're not so great. They're okay, but they're not great. They really don't tell us. And maybe that's why there's so many of them, because we can't figure out which is the right combination of factors that really defines a patient's risk. And Gestalt is just as good. So, research question number 3, what is the best way to stratify risk? What is the value of each of the multiple risk scores and stratification methods, and how do we best use them? And maybe there's some kind of overall score. So I would just say that we are at the dawn of a new era. We're at a critical inflection point with PE. There's incredible new interest. You're all in this room here. There's enormous interest by FDA, CMS, government, and practitioners. There's a host of new therapies available on the horizon. Jay, you described some of them, and there's better surgical outcomes. There's a more efficient methods to evaluate their impact, not just randomized clinical trials. We can do big data studies, we can do registry trials, and so on. And then there's this multidisciplinary collaborative efforts of PERT Consortium and others. So this provides a unique opportunity to define the optimal use of these novel therapies versus anticoagulation or lysis, to evaluate longer-term outcomes, and to remove unnecessary variation, which there's a huge variation in treatment. If you go to one hospital, you always get catheter-directed lysis. If you go to another hospital, you always get just anticoagulation alone. And people stick fiercely to their opinions about this. So we can reduce some of that variation and improve patient care if we look at this more closely. So for the acute PE and the individual patient, this is an opportunity to address the major conundrums facing the practitioner. Because when you're facing that patient in the ED or on the floor, and recognizing the presence of PE, let me tell you, there's a lot that is missed in the emergency room and sent home. And I see the litigation coming through. It's unbelievable because it's very hard to pick up. This is a great masquerader. And then for that practitioner, once you identify it, how do you calculate the risk for that individual patient? We need to research that. We need to figure that out. And then we also need to figure out in broad strokes what's the optimal therapy given that relative risk. So to that end, and I'm going to talk a little bit, I'm going to primp up Rob there. You can wave, Rob. Rob has really spearheaded this new pulmonary embolism quality registry database that is across all the PERTs in the country, just ramping up and has done an amazing job of bringing it forward. This is the founding institutions of the PERT Consortium itself. There are about 45 or 50 of them, and there are many more institutions, another 50 or so that are participating now. And this consortium, I think, fills an important need for this topic that I'm talking about. It's an opportunity to coalesce all the data. In fact, when we started PERT, we said, my gosh, can you imagine if you put all of the input from all of the different PERT centers around the country, all the different PEs, if they all loaded them up into one database, instead of waiting for 5 years to answer a question, or 10 years, or never answering an individual question, you could answer a question about one therapy versus another within 6 months or a year. That's the purpose of that was the original purpose of the consortium, and it is actually carried out in the form of the registry that Rob is spearheading. I'll just publicly, shamelessly advertise the fact that we have our 5th annual meeting of this consortium coming up this fall in Boston. Sorry, guys, I think the Red Sox are still playing then. You may have to tolerate them, but the Bruins, we'll see what happens. Anyway, so I would suggest, to get involved in this thing, put together a PERT at your institution and join the consortium. I'll talk a little bit about that next. And there's no charge for membership, but we do charge a little bit for the database. But what's amazing about it, and I'm just going to, this is Rob's slides that he just presented at our meeting, and he, so I'm shamelessly showing them, Rob. They're great. I mean, this consortium quality assurance and research database is a combination of, it's sponsored by the PERT Symposium, the PERT Consortium, which is a 501c3, but we use the REDCap Cloud database, which is it's open access, and we combine with BCRI, which is a really high-level research entity, to try to get at some of this issue and to try to answer some of these questions that we need to pose. We have nearly 1,700 patients in there already, 20 actively enrolling sites, but 50-odd sites that are still on the verge of enrolling. Starting this summer, we think they'll get to that point. What I really wanted to show you is the dashboard that Rob and his colleagues developed, which really gives feedback to everybody who submits to this database how they're doing compared to the rest of the consortium. How are you treating PE? Are you doing it in what's considered to be a quality-based way? We really need to define what is quality. That's another research question, if you will, defining what constitutes quality performance in treatment of pulmonary embolism. Are you getting these patients anticoagulated quickly, and so on? I won't go through any more, but I did, I kind of threw those slides in at the end, Rob, because I thought it's important to highlight the power, the potential power of this multi-center database that we imagine within 2 years we'll have 200 centers submitting all their PEs, and then we can start asking fundamental research questions that are pragmatic about how to treat PE and what gives you the best results, how do you stratify risk, and so on. So thank you very much.